Hello and welcome everyone. Thank you so much for joining us for this webinar, A Day in the Life of Internal Medicine. Of course, I'm biased as an internal medicine resident, but I think internal medicine is the best specialty. I'm super excited to tell you about the path to becoming an internist, a little bit about what we do, and then end with questions. I want you all to be really active in the chat. I want this to be really conversational and to do my best to answer any of your questions. I am a PGY1, which means it's my first year out of medical school. I've also been a tutor for some of the standardized exams that are part of the licensing process for folks in medicine, and have been with Med School Tutors for a number of years now, helping folks get through those exams. And I won't dwell on this a ton, but just to say that we as Med School Tutors offer mentoring, advising, and test preparation really from start to finish, from pre-med days and med school for some of the exams that come after med school. And it's a personalized model that we really want to just be the best resource that we can for you. Maybe I should only speak for myself, but we're also huge nerds, really enjoy this subject matter, and hopefully that's infectious. Like I mentioned, I'll tell you a little bit about myself and how I got here. I'll try to pepper in some anecdotes, some successes, and maybe what you would call failures along the way. I'll give you all sort of a primer on what internal medicine is, describe what it represents, and the fact that it is really the backbone of medicine in this country. I'll talk a little bit about what it's like being an intern, your first year out of medical school, training in internal medicine. I'll tell you a little bit about the path to becoming an internist. And then, of course, what I'm looking forward to most is hearing all of your questions and answering as many of them as I can. So very briefly, I grew up in Florida. I'm a proud son of immigrants from Jamaica and Costa Rica. And I was born in Boston, but I grew up and spent most of my life in Florida before going on the medical route. So I went to undergrad at the University of Central Florida, which is a very large school. And, the first thing that I would say about this part of my life is I was very lucky to have mentors who believed in me, who went out of their way to get to know me personally, who advocated for me at each step of the way. And that was critical for my success. But I also want to take this opportunity to tell you all about a disappointment. When I was in high school, my dream was to go to California for undergrad. One of my best friends went to Stanford for undergrad, and I had told all my friends and my family, like, that's what I want to do. I want to leave Florida and see something new, see something different. But the truth is that I didn't take the steps necessary to do that, and I did poorly on the SAT, which is one of those standardized exams for getting into undergrad. And I really beat myself up about not doing well and realizing that it was sort of my fault. I didn't put in the time or energy to know what it took to be successful. And I think the lesson there is partially that you have to not only want something, but then take active steps to realize those dreams. But also that sometimes when things don't go as planned, it's really okay, because I had an incredible time in college. I learned a ton. I was exposed to really a wide variety of people, and I would not change it if I could go back in time. So after my days as an undergrad, I majored in microbiology and molecular biology. I became more and more interested in research as a career. I didn't know anyone who was really doing research in my family. So the possibility of a research component to my career hadn't really been at the forefront of my mind as an undergrad. And I came to it sort of late, and I wanted some time to explore that possibility further. And that really took me to Washington, DC, and the National Institutes of Health, where I worked for 2 years in the allergy and infectious disease division there. And it was such an eye-opening experience. I was there during the Ebola epidemic and actually had patients with Ebola that were being treated at the NIH on the same floor that I was working. I got to meet the NIH director, Dr. Francis Collins, internist, by the way, and really got to rub shoulders with some of the brightest minds in medicine and in research. And I was really sort of flirting with the idea of doing an MD PhD, but at the end of 2 years at the NIH, I realized I really wanted to see patients. I wanted that to be a big part of my career. And I decided not to apply as an MD PhD candidate. I applied just for the MD track. And after applying all over the place and interviewing and then being very fortunate to have a number of acceptances, I then made my way up north just a little bit to the University of Pennsylvania. And before I talk about my time in med school briefly, I'll just say that for me, it was so gratifying to have the opportunity to take another standardized exam like the MCAT and do a lot better. And I wish I could say it was all me, but the truth is that I also had undergrad advisors that were very, very invested in me. I had good advice from friends and peer mentors who were a few years ahead of me down the road. And I think that really made a lot of difference. So the lesson here is, one, it's okay to go on a side track. And if you're passionate about research or advocacy or policy, taking some time to explore those interests is not only good for you personally, but it can also really enrich your application to medical school. And then of course, surround yourself by good people, because you all together can achieve really, really cool things. As I mentioned, I moved to Pennsylvania, to Philadelphia, where I was at Penn for med school. And this was a time of just incredible exploration. I had no idea that physicians could be involved in local politics, state politics, national policy around healthcare delivery. And I saw some of my mentors and professors really add that to their clinical career. I saw all different styles and flavors of research, for instance, which was really, really fascinating and inspired me to maybe consider that a little bit more as part of my future career. The structure of med school, as many of you no doubt know, is preclinical for 1 to 2 years. For me, it was 1.5 years. And then you do the core clerkships, where you basically speed date all of the different specialties in medicine, the core ones being internal medicine, pediatrics, OB-GYN, surgery, psychiatry, occasionally emergency medicine, as well as a few others. And it was in that process that I first rotated on internal medicine, and I fell in love with it. And that's what I'll be talking about really for the rest of this webinar. To round things out, I then took another year of research, but this time really clinically oriented research, focusing on cancer and the genetics of cancer. And that took me even further north. My parents very disappointed. I was going in colder and colder climates to Dana-Farber Cancer Institute. I was doing leukemia genomics research. And I liked it so much, the environment, the people, the research, that I ended up applying into internal medicine and was lucky to match almost a year ago today at Brigham and Women's Hospital. And that's where I am now. I'm getting close to the end of intern year. So I've mentioned internal medicine a number of times. I want to define it because sometimes it's hard to pinpoint exactly what internal medicine is. So the way I think of it is it's non-surgical care of adults. And so the American College of Physicians defines internal medicine as specialists who apply scientific knowledge and clinical expertise to the diagnosis, treatment, and compassionate care of adults across the spectrum from health to complex illness. This is, psychiatry could probably have a similar statement. We focus more on the major organ systems of the body. So the heart, the lungs, the gut, and infectious diseases, for instance. That's just a small cross-section. I'll discuss that more later. It is the largest specialty in the match. And for those who don't know, the match is the process by which med students basically acquire their first job out of med school, which is residency. And basically a quarter of all positions offered to new doctors are in internal medicine. And that really means that the world is your oyster because you have an incredible array of diverse career opportunities. And I'll go over some of them now. So really, regardless of where your interests lie, there's something for you in internal medicine. If you're a really hands-on person and really like procedures, then gastroenterology or interventional cardiology would be a great fit for you. If you're not so excited about doing procedures, but you're really interested in taking really detailed histories and basically thinking about it from a global medicine, from a global perspective, infectious diseases, IB, would be a great fit for you. There are internists who spend all of their time in the hospital. So obviously the spectrum of patients that they see is very, very on the sicker end. Or you could never step foot in a hospital after residency and basically have all of your time dedicated to the longitudinal care of adults like primary care doctors do. And of course, primary care is not just internal medicine, family medicine, OB, pediatrics are considered primary care specialties. But a lot of internists do practice primarily outside of the hospital in the outpatient setting. I sort of alluded to this in prior comments, but you really see the spectrum of illness. So in the ICUs, you're seeing the sickest of the sick patients, hopefully pulling folks back from the brink of death, and then being there as compassionate physicians to the families who are really going through a traumatic experience. On the other end of the spectrum, you can have general medicine and primary care where, you know, a good chunk of your visits are management of chronic diseases like diabetes, like high blood pressure, and it tends to be a far less sick patient population. In addition to the clinical diversity, there's a whole other set of things that you might do as an internist. You can be involved in medical education, which you'll find if you're in med school or are bound for med school, that a lot of your professors will be internists, internal medicine specialists, because they cover and they treat so many of the fundamental diseases you need to know as a medical student. It's also true in the hospital. We call the different parts of the hospital wards. So on the wards, there's so much education that happens clinically as you're taking care of patients. And of course, there are many internists who spend 80% or more of their time doing research. And that research is everything from super basic science research with cell lines or even computational modeling, all the way to advocacy at the state, local, and even international level, thinking about policy, doing public health work, global health work. These are all things that folks do within internal medicine and would be open to you if you choose that as a career. I mentioned some of the internal medicine subspecialties. The specialties listed on the screen are the specializations you can do after you complete an internal medicine residency. And this list is limited to those that have board certification. So there's a governing body that basically makes sure that there are standards for these subspecialties. And again, they really run the gamut. You'll notice that all of the major organ systems are represented here. Most fellowships are somewhere between 2 and 3 years, although often folks can be in training for far longer. So for instance, the congenital adult disease sub fellowship is something like another 4 or 5 years after residency is done. Whereas some of the other specialties that are not so niche and specialized can be 2 clinical years after residency is complete. And I've been alluding to residency, and so I'm doing this a little bit backwards, but the actual process of coming out of med school as a new doctor and becoming an internist happens during residency. And there's a couple of different flavors that residencies can take. The most common is called the categorical residency. This is 3 years long. It's inpatient focused primarily, although there is a significant component that is outpatient medicine, where you get to longitudinally take care of patients as their doctor. There are versions of a categorical residency called primary care tracks, where the focus is far more on the outpatient side. And that's for those individuals who foresee themselves being primarily outpatient primary care doctors. I've mentioned research a few times, both because I love doing research and it's a big part of residency and training. But for those individuals, particularly with PhDs, who really want to move as quickly as possible back to the lab, there is a short tracking option. Sometimes it's called fast tracking. This is 2 years. It's a pretty intense 2 years because you're cramming essentially 3 years of being a resident into 2 years. But then after you gain a year on the back end to then do research as a fellow or as a postdoc. A number of programs also have global health offerings. Some of these are 3 years, some of them are 4 years, and you spend that extra time really developing expertise and experience in going to under-resourced areas, or even just learning about different healthcare systems. And so that adds an extra year to training in a subset of programs. And of course, there's a bunch of other little tweaks. The two that I'm familiar with, because there's options for these where I go to residency, is to get an MBA during residency. And there's often a management and leadership track where folks specialize in the delivery of healthcare at a larger scale. And then there are unique programs, something like a HemiDoc, which is where you do 50-50 research split during residency. And that's either 3 years if you short track or 4 years if you don't short track. Again, this is decisions that folks don't make until they're in residency already. I couldn't help but bragging about internal medicine a little bit. There are a ton of famous internists, but some that you all might be familiar with. So Tony Fauci, in the pandemic, obviously he's a big figure. He is at the NIH, and he's an internist and an infectious disease doctor who really, and is one of the most cited researchers of all time, actually, because of his seminal work in HIV and infectious diseases more broadly. Vivek Murthy, who's a Surgeon General nominee, also an internist, the founder of Partners in Health, the major global health organization created by Paul Farmer and his colleagues, is an internist, along with like former World Bank presidents. Really, folks after internal medicine do a variety of really cool and interesting stuff. So I wanted to walk you through what a day in the life of an intern, which is, again, is the first year out of med school in internal medicine, is like. I typically wake up around 5:30 a.m., which for me, as sort of not a morning person, can be painful at times, but it's better than on surgery, I will say that. And I head to the hospital around 6:30 a.m. And then the morning is spent predominantly pre-rounding. And for those who don't know, pre-rounding is the process of hearing what happened to the patients who are under your care over the course of the night. You go visit each patient and you have a conversation with them about how they're feeling. You ask them questions that are relevant to why they're in the hospital. And then you do a physical exam to give you data on, how their disease is progressing and whether the interventions that you're proposing and doing, if they're working. And so that typically takes an hour or two. And then after you pre-round, you round, and that sort of makes sense. And what rounds is you have the attending physician who's the leader of the team and is the physician of record. You have the trainees, typically a senior resident, either in the second or third year of residency, who is sort of leading the team and making sure tasks get done. You have the interns who have the primary responsibility for caring for patients. And then you have often the other healthcare professionals who are there to provide their input and to sort of come up with a plan together for the day. And that includes nurses, that includes pharmacists, as well as a variety of other folks that might be on the team. And the structure of rounds, it's a little bit flexible, but typically what you do is you walk to the patient's room. The intern who is taking care of that patient then presents what happens over the course of the night and what they discovered that morning to the team. They then propose a plan, and the plan then gets discussed first by the resident and then by the attending, and then is finalized. And after that, you then go talk to the patient. You make sure that you're answering all of their questions. You update them on what the plan for the day is, and then you move on to the next patient. And a typical intern will be responsible for somewhere between 6 and 10 patients. So a team will take care of usually around 20 patients, 15 to 20 patients, if there are 2 interns on the team. Then sometime around noon into the afternoon, you have educational conferences. And these are some of my favorite activities to go to as a med student and as an intern, where you get to learn from experts. And this is a picture I pulled off of Twitter of a senior resident in my program, Amin, who is giving a lecture on diffuse large B-cell lymphoma. And sometimes it is relatively informal teaching, just like you see in the picture. Sometimes it's a faculty member who is giving a prepared talk, all the way up to medical grand rounds where you have visiting professors who give talks on areas of their expertise. After you do those educational conferences, you then complete tasks. And those tasks are typically giving medications, following up on labs, ensuring smooth transitions from inside of the hospital to outside of the hospital. And then around 5 p.m., you start wrapping up. And what that means is the night team shows up. You update the night team on what happened during the day. You give them instructions for things you'd like to get done over the course of the night, as well as give them anticipatory guidance. In other words, this patient's sick. If they get sicker, this is what I would do. And after you've handed off your patients, you can then leave the hospital and go home and do all the things that you would normally do: have dinner, exercise, watch TV, read a book, whatever it is. And sometimes I will admit that you leave the hospital and there's still things that need to be done. So you might log into the computer and complete those tasks if you have remote access to the electronic medical record. I will have one slide on this, and obviously there's so much more to getting to internal medicine than can be fit into one slide. And it's a fitting last slide because I hope to be hearing questions from you all, and we'll then answer them. But briefly, you first have to be a pre-med and apply to med school, get into med school, do med school, which most of the time is 4 years, but there are some programs that are abbreviating it to 3, obviously more if you get advanced degrees. As a 4th-year medical student, you then apply to residency. And I'm happy to talk about any and all of these steps. After you match into a residency, that is somewhere between 2 and 4 years for internal medicine. I talked about the different tracks that can alter how long residency becomes. You don't have to do a fellowship. Some people stay as generalists, and some of the smartest, most capable, highest impact researchers are general internists, and they don't do further fellowship training. However, if you do want to subspecialize in a particular field, you can do that. Again, typically somewhere between 2, 4, and very rarely maybe 5 extra years of training. And then once you're done with training, either at the end of residency or at the end of fellowship or fellowships, you become an attending. And as an attending, your split of what you do is really up to you. Some people are full-time clinicians in the hospital, full-time clinicians outside of the hospital, or they mix a little bit of something else in there, 20% of clinical and 80% of research or policy or education or administration, et cetera. So that's the big picture roadmap of how one gets to internal medicine. with that, again, I'll just put this up here because I will admit that the road is very, very long, and all of us at some point in life need help. And sometimes that help comes from family, from friends, from formal mentoring relationships. But sometimes you need someone in your corner to help you with these various transitions in life. And so I'll just say that we're here for you if you ever feel like you would benefit from having someone talk you through a standardized exam, how to approach it, strategies, and our contact information can be found at the bottom of the slide. Again, it's super customizable to your needs and in your specific situation. It's all about mentorship, support, and guidance, like the slide says. So please reach out if you feel like that would be helpful. Don't suffer in silence if there's something that you would like to discuss. And with that, I'm looking forward to your questions. Is there anything you wish you knew about your intern year beforehand? And the answer is yes. I feel like with all of these transitions, retrospect, hindsight is 2020. And I think it's really important to get a sense of how important the details of your schedule are and how that fits into engaging with the people that you love and the important people in your life. So I wish I had asked more questions about precisely how the schedules should shake out, the timeline of these things. And I say that because my brother's getting married. I have a number of other important family things that have all been, delayed due to the pandemic. But regardless, it would have been nice to know some of that in a little bit more granular detail. I'm happy to talk about other aspects of intern year. For instance, when do you want autonomy? How front-loaded or back-loaded do you want the residency experience? These are things that I think deserve a lot of attention. But I'll leave it there and see if folks have any other questions. And maybe what I'll do actually at this point is, if you all wouldn't mind putting in the chat what stage of medical training you're in. Are we pre-meds, medical students, what year in medical school? I would love to know so that I can sort of target the answers to where you all are at. A common question that I get as you all are thinking about any questions is, well, how do you know which specialty to apply for? Often folks feel like, I liked everything as a med student, and it can be difficult to make a decision. For me, I think there were some key branch points that were really important. One was, do I primarily want to do procedures? Do I want to do something surgical? Or do I want to do something non-surgical? So that's a big branch point right there. And for me, I think doing surgeries is cool. You can have an immediate and very powerful impact in the life of a patient. But I didn't want to be in the OR all the time. And so that really cut out general surgery, ENT, plastics, as well as the other surgical subspecialties, orthopedics, et cetera. Then I asked myself, well, do I want to take care of adults or do I want to take care of children? And some people, don't want to answer, or not, it's not that they don't want to, but it's a question that's not relevant to them because they want to do both and they do family medicine, or there are med peds where you do both a medicine and a pediatrics residency. They shave off some time in the middle, so it's 4 years instead of 3 years. But for those who do have an opinion one way or the other about which specialty they would like to pursue or which age range they'd like to pursue, then that's really helpful because then you can cross off peds or you can cross off internal medicine. After that, thinking how broad or narrow do you want your scope to be? There's another, I mentioned psychiatry before, treating adults and children with mental illness, but that's it. It's just mental illness. And I shouldn't say it like that. It's not just mental illness. It's extremely challenging, a huge need. If you're interested in psychiatry, please apply into it. Some of my best friends are psychiatry bound. But I personally wanted to think about the heart and the lungs and the bone marrow, and also manage psychiatric disease, at least in the forms that are amenable to being treated by a primary care doctor or an internist. So that was a big consideration for me. Sometimes length of training is important. For me, I sort of wanted to get to research into an attending life, so it was attractive to go for a specialty that was a little bit on the shorter end. So those were some of my considerations. And I'll pause again for 10, 15 seconds here to see if anyone has any questions. There's a good question that just came through the chat. Are DOs viewed any differently than MDs in internal medicine? So what I will say to that is, first of all, DOs are, and this is obvious, but DOs are fully, as physicians, taking incredible care of patients, have a really cool additional skill set. And any situation in which they're treated differently is essentially not fair in my opinion. I think that the reality is that internal medicine is so big that physicians that come from an osteopathic background can easily become internists. And I don't believe that there's any stigma from that perspective. The reality of the situation is that the quote unquote prestigious programs have historically not taken folks with an osteopathic background into their programs. So, and I think that that's, a disservice to the program, but that's just the way it is. For instance, at my residency, I don't think that there's a single individual with a DO background as part of the intern class. But again, hopefully as the match gets unified across DOs and MDs, which it has already, and as we gain more and more experience essentially with taking folks into their program and they do amazingly well, even that stigma hopefully will pass. The last comment I'll make is, how do you pick an internal medicine program? And the truth is just like with any step where you're making a big life decision, it's thinking about what matters to you and what do you want out of the experience and in what environment will you thrive. So that's vague, I'll be more specific. Thinking about location, super important. Thinking about, is the program known for any particular subspecialty? So for instance, Brigham is good at a lot of things, but they're really well known for cardiology and for oncology. I want to be an oncologist. So that was a big consideration for me. Is there a good mentoring structure? Do they have a focus on equity, inclusion, diversity? Do they welcome folks with a variety of backgrounds and perspectives and cherish them and make them thrive? So those are just some of the things that were important for me when I was making my decision. And hopefully that's useful for you all. All right, well, I'm not seeing any other questions. I want to thank you for joining us today. I hope this was really useful wherever you are along your medical training journey. I'm rooting for you all, and it can be long, but ultimately it's really satisfying because you get to take care of people in their most vulnerable moments. And so with that, I'm wishing you all the best wherever you're at. Please reach out if you have questions, concerns about anything that we've talked about. And I hope you have a wonderful evening. Bye, everyone.